The next speaker is Dr. Khalid Amin, who is a colleague at the University of Minnesota here. He's an associate professor of pathology and is both a cytopathologist and also a GI pathologist. So he's going to be sharing his experience with us about cytology and pancreatic lesions that you see, Dr. Amin.
Thank you, Dr. Day, for your kind introduction. Good morning, everybody. So my presentation today is basically case-based, and what I'm going to show you is a collection of cases that we have seen in our practice over the years that include both solid and cystic pancreatic neoplasms. Some of these entities are rare entities, but showed very classical features. Other cases are more common neoplasms, but they presented with atypical morphological or clinical picture. So our first case is a 65-year-old woman who was evaluated for abdominal pain and jaundice at an outside hospital. CT scan revealed a 3.4 centimeter suspicious appearing mass. EUSFNA performed at the outside hospital did not show any definitive evidence of malignancy. The patient was referred to our institution where a repeat of EUSFNA was performed. And this is the low power image of a diff-quick stained smear. As you can see, it is not very cellular, but it is composed of discohesive, variably sized groups of epithelial cells that overall, if you look at it, the appearance is a little bit worrisome, but if you look at the cells, they look rather bland. On high power, they actually exhibited very characteristic cytomorphology. As you can see, they have abundant cytoplasm that has a foamy or a microvesicular look. The nuclei were mostly round with very minimal atypia. The pap stain smears actually were not that cellular, had few groups, and over here you can see one with very mild focal nuclear atypia. The cell block showed the presence of these strips, these epithelial strips and groups of cells, which look quite similar to what I showed you in the previous slide, the diff-quick stain slide. They looked a bit atypical, but not striking, not enough for us to just call it malignant. So based on that, overall features, we ended up calling this as suspicious. But our clinical team wanted a more definitive answer to initiate the treatment. So they requested the procedure to be repeated. The repeat sample was a bit more cellular, but showed a similar cytomorphology, as you can see over here, cells with with abundant cytoplasm and these fine microvesicular appearance. The pap stain smears actually showed a bit more atypia, as you can see, at least focal, nuclear atypia is seen over here. The most helpful actually preparation in this repeat sampling was actually the cell block, which showed these groups, epithelial groups with abundant foamy cytoplasm and racinoid nuclei. Also present were these stromal fragments of stromal tissue that were infiltrated by these small, very abnormal appearing glands with irregular outlines. So based on all these features, we were able to call this malignant. The patient underwent a neoadjuvant chemotherapy and a Whipple resection was performed. On Whipple resection, this is one of the section that is actually showing presence of these very bland appearing glands, as you can see over here. These are lined by cells with very foamy type of cytoplasm, similar to what we see on cytology. If you focus on the apical zones of these cells, they show this characteristic chromophilic condensation that gives it a brush border-like appearance. Similar type of cells were also seen lining some of the ducts. Also present within the same resection specimen areas that were frankly malignant. As you can see over here, these are very atypical glands lined by cells with marked nuclear atypia. Also, over here, you can see a gland that's showing perineural invasion. So what I just showed you is an example of a pancreatic ductal adenocarcinoma with foamy gland pattern. This is a very deceptively bland appearing distinct morphological variant of pancreatic ductal adenocarcinoma that can cause diagnostic challenges. As you've seen in this case, it took us 3 FNAs repeated 3 times to get to the final diagnosis. Isolated examples of this entity were first reported in the 80s and the 90s. However, the most comprehensive and detailed report was published by Adsey et al. in 2000 that included 20 cases. 4 of them were pure foamy gland variants and 16 had intermixed ductal adenocarcinoma. In the study, they also showed that these foamy glands have a distinct staining pattern with certain histochemical stains. Over here, if you look at it, this brush border light zone of these glands shows strong positivity with mucicarmine stain, Elchin blue, PS, and high iron diamine with Elchin blue, which signifies actually the presence of sialylated acid mucins, which have been shown to be the most predominant mucin types in pancreatic adenocarcinomas. We actually did a retrospective study to identify causes that leads to repeat FNA procedures. And in the 5-year span that we looked at, we found 27 cases that had repeat procedure. A total of 58 procedures were performed. And of the several of the causes that are listed here, as you can see, in 6 cases, it was the challenging morphology that resulted in repeat procedures. Out of these 6 cases, 4 were actually adenocarcinomas with extensive foamy gland change, which highlights the very bland nature of this entity that can lead to diagnostic difficulties and delayed diagnosis. So next I'm going to present a pair of cases that shows the morphological spectrum of this entity. So our first case is a 59-year-old man evaluated for abdominal pain and progressive difficulty in swallowing, leading to discovery of a pancreatic tail mass. And this was at an outside hospital. On CT scan, in addition to this pancreatic tail mass, there was a very large peripancreatic mass, and also enlarged mediastinal and retroperitoneal lymph nodes were seen. All these 3 different sites were sampled, and we actually got the samples from the outside hospital and reviewed it. And as you can see, these smears, different quick stain smears, are very cellular, and they are composed of discohesive that look like really high-grade type of cells. They over here, if you look at the high power image, it shows that they have variable amount of cytoplasm. Some of them actually look like plasmacytoid. There are also occasional group that showed glandular differentiation. This is the PAP stain that highlights the nuclear feature, which were characterized by presence of these very prominent nucleoli. And also, if you look at the chromatin, it is granular and has a neuroendocrine-like appearance. The cell block actually showed fragments of predominantly a solid high-grade neoplasm with occasional glandular elements, as you can see over here and here. By immunostaining, most of the tumors show positivity with synaptophysin. However, chromogranin was focally positive. Additional stains performed show patchy positivity with trypsin. And also there were scattered cells that showed positivity with PSD. since there was a significant neuroendocrine component, we did the Ki-67 stain, which showed greater than 50% positivity, which is consistent with high-grade neuroendocrine carcinoma. So this actually is a case of a mixed neuroendocrine acinar cell carcinoma. The next case on the same theme is a 66-year-old woman who presented with obstructive jaundice and a 50-pound weight loss in 1 year. Imaging revealed a 44.4 centimeter pancreatic head mass. FNA was performed at an outside hospital. It was called positive. The patient received neoadjuvant chemoradiation with excellent response. She came to our hospital for a Whipple resection. Over here, first I'm going to show you the cytology specimen, which we received the cytospin preparation. As you can see, it is quite cellular, and it is composed of mostly disc-cohesive high-grade cells. However, there are occasional clusters where you can actually see vacuolations in the cytoplasm. And also there were some clusters that exhibited glandular type differentiation. The cell block, if you look at this cell block, it is almost, it is quite similar to the previous case, showed predominantly a high-grade solid neoplasm with some glandular elements. So this tumor showed patchy positivity with synaptophysin and CD56. Resection that was performed at our hospital showed a high-grade, predominantly solid neoplasm with variably sized large nests in trabeculae. Also, if you note, there are some glandular elements that are kind of very intimately intermixed with these solid areas, seen on this high-power images. Over here, you can see these glandular elements that are intermixed with the high-grade solid neuroendocrine carcinoma-like areas. So the staining was consistent with what was seen on cytology. It showed mostly the cells were positive for synaptophysin. Chromogranin was focally positive. We also did trypsin, which in contrast to the previous case was negative. But as you can see over here, this is a mucicarbamine stain, which shows scattered presence of these mucicarbamine positive cells and glandular elements that again appear to be very intimately associated with, or they're intermixed with, the solid neuroendocrine component. Ki-67 was performed again to grade the neuroendocrine component, and it was greater than 50% and consistent with neuroendocrine carcinoma. So these two examples were the examples of mixed neuroendocrine non-neuroendocrine neoplasm, or MINEN. These are rare neoplasms, and in order to qualify for this diagnosis, each component has to represent at least 30% of the tumor. In most cases, both components are of high grade, like what we saw in both our cases. It was a high-grade neuroendocrine carcinoma. And the non-neuroendocrine components typically are ductal or acinar type. Both components can be intermingled, as we saw in our cases, or they could be also distinct. And it is important to grade the neuroendocrine component by Ki-67 because it is this component that dictates the biology of this entity. Its prognosis is slightly better than the pure neuroendocrine carcinomas, 20 versus 12 months. Another thing I would like to just mention on this, that immunohistochemistry is essential in diagnosis of these tumors. As you can see, the morphology can be very mixed. It is by application of immunohistochemical stains that will get you the right diagnosis. So next case is a 90-year-old man presenting with worsening dysphagia and further workup revealing a pancreatic mass. On EUS, a 3.6 centimeter heterogeneous solid mass was seen with poorly defined borders. So these are the cytological preparations. As you can see, they're quite cellular and are composed of irregular, very crowded groups. And if you look at these clusters, they have a little bit of grape-like appearance. And also seen within the clusters, you can probably pick out some vague acinar formations. In the background, a few naked nuclei are seen. But the characteristic picture is seen in features is actually seen on this high power image that shows the frothy background, which is actually caused by rupture of these very delicate cells that spill their zymogen granules. So this is a feature to look for in this entity. On Pap stain, the nuclear show mild to moderate atypia and are characterized by prominent nucleoli and coarse chromatin. The cell block showed a tumor which a predominantly microacinar and pseudoglandular pattern, and it showed diffuse strong positivity of the cells by PAST. The tumor also by immunohistochemistry showed a patchy weak positivity for synaptophysin, and trypsin actually was the diagnostic stain that showed diffuse strong positivity. So this was an example of acinar cell carcinoma, which are quite rare, and they can actually present as large masses that can sometimes undergo cystic degeneration. Clinically, they can, in a small subset of patients, they can produce hypersecretory syndrome, which is caused by hypersecretion of lipase, and it causes disseminated fat necrosis, polyarthralgia, and eosinophilia. As seen in this case, these specific immunohistochemistry markers are key in diagnosis. So this tumor is positive for trypsin, chymotrypsin, and BCL10. Our next case is a 15-year-old boy presenting with abdominal pain, and CT scan revealed a cystic lesion. On EUS, a 2.4 centimeter complex cystic and solid, well circumscribed round lesion was seen in the pancreatic body. And by EUS, its appearance was most suggestive of a cystic pancreatic neuroendocrine tumor. The cytological preparations, as you can see show over here, these very characteristic papillary-like structures with very delicate vessels passing through their center. And these vessels appear to be lined by multiple layers of these cells. Also seen are these other type of clusters which show a core of metachromatic hyalinized matrix material. On Pap stain, they showed the nuclei have very fine chromatin. Many of these cells show very prominent grooves. And also, if you look at it over here, some of these cells appear to have tails. So these are actually called Silicary-form cells. These was first actually described by Dr. Kumbuchian, who was our former faculty in our department and unfortunately passed away earlier this year. The cell block showed characteristic features. As you can see, it has a pseudopapillary appearance, and these papillary cores have hyalinized vascular cores. The diagnosis was achieved by demonstration of both nuclear and cytoplasmic positivity of these tumor cells with beta-catenin, and also they were positive for progesterone receptor. So we call this a solid pseudopapillary neoplasm. The patient underwent a resection, which confirmed the cytological diagnosis. As you can see over here, it shows the classical morphology characterized by presence of these clefts with areas of hemorrhage, pseudopapillae with hyalinized fibrovascular cores, also some myxoid areas, some degenerative changes like formation of these cholesterol clefts. And on high power, you can see the characteristic intracytoplasmic hyaline globules. So this is a tumor that is kind of rare, seen mostly in young women, and it is seen mostly at the location is the tail. These are low-grade tumors that can metastasize and can also occur in extrahepatic sites such as extrapancreatic sites such as mesocolon, retroperitoneum, liver, and duodenum. So this is a table that actually highlights the cytomorphological features of these three entities. Since both these three tumors, the pancreatic neuroendocrine tumor solid, pseudopapillary neoplasm, and acinar cell carcinoma, can have overlapping morphological features. The cytomorphological features, as illustrated over here, are helpful, but actually the diagnosis is highly dependent on demonstration of the specific IHC markers, which, as we have seen for pseudopapillary neoplasm, it's beta-catenin, progesterone receptor, and CD117. And for acinar cell carcinoma, it's trypsin, BCL10, or chymotrypsin. So next I'm going to present two cases side by side, not only to demonstrate the morphological spectrum of this entity, but also the outcome. So our first patient showed had cytological smears that showed these presence of these multinucleated osteoclast-like giant cells. And also, if you see in the background, there's a mononuclear population. The nuclei of both these multinucleated giant cell and the background mononuclear population look very similar. The atypia in the background mononuclear population was moderate. In contrast, the other case showed very hypercellular smears that were composed of this discohesive, highly pleomorphic cells with bizarre nuclei and very atypical mitotic figures. This is the cell block that show the osteoclast-like giant cell component mononuclear cells. We also saw these atypical glandular elements, which at that time we just disregarded as probably reactive. And on the second case, similar to what we saw on smears, it showed a tumor which was very pleomorphic, composed of these seeds. So this patient actually underwent resection, and it's more than 5 years since diagnosis, and this patient is still alive. The other patient died within 4 months of diagnosis. So the resection specimen on this first case, in addition to the osteoclast-like giant cell component of an undifferentiated carcinoma, we saw conventional ductal adenocarcinoma. And both in this image, this is an image of a lymph node that show metastasis by both of these components. In the other patient, autopsy was performed that revealed a large pancreatic mass with similar morphological features to what we saw on cytology with widespread metastasis. So these two cases were examples of undifferentiated carcinomas of the pancreas. They are basically divided into two types, the one with osteoclast-like giant cells and others without. The reason for this is because this first entity many studies have shown that it has a significantly better prognosis. And as we saw in the case that I presented, the patient is still alive after 5 years. They can, in many cases, they are associated with a conventional adenocarcinoma component that we saw also in our case. The undifferentiated types are highly aggressive tumors. They have overlapping morphologies and can be classified into the anaplastic type, which we just saw, the sarcomatoid type, or the carcinosarcoma. So our next case is a 67-year-old man with a history of kidney stones presenting with acute flank pain, and imaging revealed a pancreatic tail mass, an adrenal mass, and also a right renal mass. EUS showed a 4 centimeter round heterogeneous pancreatic tail mass with well-defined borders. Also seen was sonographic evidence of encasement of the splenic artery and vein. The cytological smears that you see over here, they have a very characteristic morphology. You see these large groups which show these transgressing blood vessels. And these blood vessels are actually lined by disc-cohesive tumor cells. And if you look at the tumor cells, they show abundant cytoplasm with this characteristic microvaculations. And if you look at the nuclei, they are round and they are peripherally located. And in some cells, they appear to be ready to be extruded. So this is the classical morphology of renal cell carcinoma. In this case, the cell box confirmed the diagnosis. As you can see nicely, the clear cell morphology and positivity of the tumor with Paxate. This is a table from one of our studies where we looked at the pancreatic neoplasms diagnosed in our institution from 2006 to 2016. And as you can see from the table, metastatic renal cell carcinoma was by far the most common metastatic neoplasm, accounting for 40% of all metastatic tumors. And it was by numbers, it was also these, it was seen more often than some of the rare primary pancreatic neoplasms. From here on, I'm going to present cases of cystic neoplasm of pancreas. So for evaluation of pancreatic cysts, the management and diagnosis of these cysts requires an interdisciplinary workup with the primary goal to identify high-risk cases. The low-risk cysts are typically followed up and are only dissected if the patient is symptomatic or when definitive diagnosis is not possible. High-risk cysts, which mostly includes mucinous cysts, have high risk of harboring invasive carcinomas and are, in most cases, are resected. Carcinoembryonic antigen is the most widely used cyst fluid tumor marker that is used for risk stratification of pancreatic cysts. It is increased in the mucinous neoplasms, and at the traditional cutoff of 192, it has an accuracy of about 80%. However, some recent large-scale studies have shown, have questioned the accuracy of this tumor marker. Therefore, there has been an increasing trend to develop molecular testing. Several molecular markers have been identified and studied, of which GNAS and KRAS mutations appear to be most promising, since they can be seen in up to 80% of mucinous neoplasms. So our next case is a 78-year-old man with suspected solid pancreatic neoplasm. EUS showed a 3.8 centimeter solid and cystic mass in the pancreatic head with duct dilatation and this characteristic mucin blob noted at the ampulla. The cytological preparations show this characteristic papillary formations. On high power, you can see some of these have a central fine blood vessel. And also seen were these round bud-like cohesive epithelial groups that were composed of rather bland appearing cells with abundant cytoplasm and no significant nuclear reticular. The Pap stain smears show this characteristic thick pollard-like mucin and strips of mucinous epithelium with basally located nuclei. The cell block showed again these papillary structures, the cross sections. You can see the cross sections, and they are lined by mucinous epithelium that have gastric foveolar type morphology. So this case was signed out as mucinous neoplasm with low-grade dysplasia, most consistent with introductory papillary mucinous neoplasm, or IPMN. The patient underwent resection, which confirmed the diagnosis is made on cytology. As you can see, this is the section of a duct which shows this papillary neoplasm forming papillary fronts. And on high power, on a high magnification image, you can see the cross sections of these papillae, which have a fibrovascular core and lined by mucinous epithelium. And even a higher power image show the gastric foveolar type of morphology of the epithelium. And also look at the nuclei, they have basal polarity and no evidence of high-grade dysplasia. So intraductal papillary mucinous neoplasms are one of the most common primary cystic neoplasms of the pancreas. Most of them are located in the head. And depending on the location, they can be divided into main duct type, branch type, or mixed types. It is very essential whenever you are evaluating these neoplasms to grade the dysplasia, which is typically graded using this two-tier scheme into low grade and high grade. This replaced the older scheme, which was a three-tier scheme, and the dysplasia was graded into low grade, intermediate grade, and high grade. Now the low grade and intermediate grade are both categorized as low grade. These tumors, 60 to 80% of these tumors harbor KNAS and also GNAS mutations. Histologically, they can be classified into the gastric type, intestinal type, and pancreatic biliary type. But it is not uncommon to see an IPMN with multiple types of lining. So the gastric type, which shows gastric foveolar type of epithelium, is the most common and has the least association with high-grade dysplasia. The intestinal type typically show tubular adenoma-like epithelium. It is the second most common and has an intermediate association with high-grade dysplasia. The pancreatic biliary type is the least common, but has the highest frequency of high-grade dysplasia. And it typically have this micropapillary morphology. When evaluating mucinous neoplasm, one of the essential tasks for the pathologist is to recognize and identify and report high-grade dysplasia as seen over here, which is characterized by significantly marked ATP as compared to low-grade dysplasia, which is seen over here. This is a table from one of the earliest studies that looked into the cytomorphological characteristics of low-grade and high-grade cells in IPM and cyst fluids. And what they found out that the three features that are highly associated with high-grade cells are increased NC ratio, chromatin pattern changes such as hypochromasia and hyperchromasia, and background necrosis. Although small percentage, but not an insignificant number of IPMNs, they show association with, they harbor invasive adenocarcinomas. The most common IPMN-associated adenocarcinomas are actually ductal types. And in one recent large-scale study that was published actually this September, where they looked at more than 500 cases, they found that 5% of their IPMNs were associated with ductal type of adenocarcinoma. The other type of, other variant of this pancreatic adenocarcinoma, which is called the colloid carcinoma, is much less common, but it is almost exclusively seen with IPMN. And one of the characteristic or one of the feature of this tumor is that it has a much better prognosis, which is much less aggressive. And it is characterized by presence of these invasive mucin pools, where you can see mucinous epithelial strips floating. So our next case is a 67-year-old woman with incidentally found pancreatic tail mass. Initial FNA performed at an outside hospital showed low CA and benign cytology. The patient was referred here where repeat EUS was performed that showed an atypical appearing thick-walled cyst measuring 2.4 centimeter in greatest dimension. There was a cystic region that was aspirated, and the cyst fluid chemistry showed that a very high level of CEA of almost 4,000. The cytological smears, as seen over here, they show two types of cell population. This population seen on the top looks very bland, and then there were epithelial groups that showed atypical cytomorphological features. On high power image of these atypical cells, as you can see, they are large cells with two-tone cytoplasm. If you look at the nuclei, they are kind of small, not that big. There's no hyperchromasia. The NC ratio is low. They have a prominent but small nucleoli. So overall, if you look at it, it gives you more of a reactive look rather than dysplastic look. Also, present were these multinucleated giant cells. This is the cell block that showed this characteristic strips of these cuboidal cells with eosinophilic or pink cytoplasm. They appear very bland. They were positive for CK7, but negative for any squamous markers. So we called it actually atypical. And because of the atypical imaging findings and atypical cytology, this patient underwent resection. And this is a section of the cyst wall that shows rather heterogeneous cyst lining, which was denuded in several areas. Most of the stroma that we saw was hyalinized. However, there were these darker areas that were composed of these bluish spindle cells. On high power, you can see the cyst lining. This is a cuboidal, which they describe it as biliary type of epithelium. This was the predominant lining that we saw. There were a few areas that showed the stratified lining, the cells that showed mostly reactive look, and I think this corresponds to the atypical cell groups that we saw on the cytology. No mucinous epithelium was seen in this case. It was entirely sampled. However, we were able to make the diagnosis of mucinous cystic neoplasm in this case by demonstrating estrogen-positive stromal cells. And this was a very unusual case where no mucinous epithelium were seen, but these cases have been reported. This neoplasm occurs almost exclusively in females, although some cases have been reported in males, and I've seen it myself. We had a case that occurred in a male patient. More than 90% are located in the tail. They typically are multiloculated cysts without any connection to the pancreatic ducts, and they have a high risk of harboring invasive carcinoma. The cyst lining, although we always think that this is a mucinous adenoma, it will have a mucinous lining. That's not the case. Actually, there's a very nice large-scale study that was published in 2017, and they demonstrated that many of these cases actually don't have, or the predominant lining is not the mucinous lining. It is actually the biliary or this cuboidal lining that we saw. And in this case, as the example seen over here, you can see both, the biliary type cuboidal epithelium and the mucinous epithelium. However, one thing I would like to mention is that if you see a tumor with predominantly biliary type of lining, the chances of high-grade dysplasia is very low. Actually, in their study, they did not see any high-grade dysplasia in this biliary type of lining, but it is more commonly associated with mucinous lining. Again, with this entity, the demonstration of ovarian type stroma is essential, as seen in our case. That is the only way we could prove that this was an MCM, which is typically positive for progesterone estrogen receptor, inhibin, and calretinin. 50 to 75% of these cases actually show KRAS mutations, but not GNAS, as seen in IPMMs. So next case is a very interesting case that we recently saw. The patient is a 79-year-old man with enhancing pancreatic head mass, picked up on surveillance CT scan after the patient underwent resection for clear cell renal cell carcinoma. On EUS, it was a 1.3 centimeter discrete round mass that was difficult to locate, and it showed no evidence of cystic change. So the FNA smears actually showed bland, cohesive cell clusters. And as you can see in this high power Pap stained smear, image of a Pap stained smear, that these cells have very round, kind of bland nuclei, but characteristic, abundant, clear, almost clear cytoplasm. On cell block, what we saw was what it appeared to be back-to-back glandular structures lined by these cuboidal, bland-appearing epithelium with clear cytoplasm. Since this patient has a history of renal cell carcinoma, and we thought that it was going to be a renal cell carcinoma, we did Paxate, which was totally negative, to our surprise. Then we started thinking about different entities, and we did additional immunostains and histochemical stains. So this lesion actually showed focal positivity of the epithelials of the lining cells with inhibin. However, the most helpful stain was PAS and PST. As you can see, these cells show intense positivity, diffuse positivity with PAS, which was washed away by diastase digestion. So this was a very interesting and rare case, which this is the first time I've seen it, of a solid variant of serous cyst adenoma. These can actually, on imaging, they can present as enhancing neoplasms or enhancing masses. And when we gave this diagnosis to our clinicians, they actually did not believe us. They really did not think that serous cyst adenoma could be solid, but about 2% of these cases can have solid morphology, and they can be mistaken for other solid neoplasms. However, most common morphology of this entity is actually microcystic. More than 70% have microcystic morphology, as seen in this image, with cysts, which might range from a couple of millimeters to 1 or 2 centimeters, and they're lined by these very bland appearing cells with clear cytoplasm. And they, on imaging, they appear as well circumscribed multi-locular cystic lesions with soap bubble appearance, and they show a central scar with sunburst pattern of microcalcification. The lining cells are rich in glycogen, that is why they are PS positive, and they have been shown to be positive for inhibin and MUC6. Our last cases are actually, again, it's a pair of cases that illustrates atypical presentation of some common entities, and also the importance of adequate sampling, how sampling can make a difference in the diagnosis. So both patients presented with cystic lesions. On this first patient, only actually cyst fluid was aspirated and submitted. In the second patient, they aspirated the cyst wall, and also because they saw thick wall, they did FNA of the cyst wall. This is the cytospin preparation from the first case. As you can see, it shows a lot of debris in the background and very few cells with round dark nuclei. You cannot make out the chromatin that easily because of significant amount of degenerative changes. So this actually was called negative because of the paucity of cells and no definite, worrisome features. This was called as negative. The patient underwent resection because on follow-up, the imaging was a little bit suspicious, and it showed a cystic pancreatic neuroendocrine neoplasm. And if you look at this high-power image, it shows that these cells are exfoliating from the cyst wall, and they are undergoing degenerative changes. The nuclei are very dark, which are similar to what we saw in the cyst fluid, and we at that time disregarded it. The other case, however, showed cells which had much better preserved morphology, and you can actually see the neuroendocrine pattern and of the chromatin. However, what made the difference in this was the aspiration or the fine-needle aspiration of the cyst wall that showed this classical morphology of a well-differentiated neuroendocrine tumor with plasmacytes, cytoid type of cells, and positivity with chromogranin. It had less than 3% of the cells that were positive for K67, which is consistent with a well-differentiated neuroendocrine tumor grade 1. Cystic change in pancreatic neuroendocrine tumors is actually not that rare. Some of the recent studies have shown this phenomena to occur in 13 to 70% of these neoplasms. And because CEA and amylase are not very helpful, a lack of knowledge of this phenomena can lead to actually undersampling, especially if the person who's sampling is not familiar, they will just not sample the wall. And also, whenever you are looking at cystic fluid, keep this in mind, especially if you're seeing round cells, always look for the neuroendocrine features so as not to miss it. So with this, I will end my presentation, and thank you so much.
So the next speaker is Dr. Mark Luquet, who I see is getting ready. So I'm going to start by introducing him. For some of you at the U, you don't really need much introduction for Dr. Luquet. But Dr. Luquet is a pediatric and perinatal pathologist, and he has a very strong background in basic sciences. He's very experienced, looking at all the bumps and things within the pediatric, gastrointestinal tract. So, Dr. Luquet, welcome. Let me see. Okay.
What it's on the schedule for 45 minutes.
So there's a gap in that schedule there, but we're going to just go straight ahead with the presentations. I believe everyone that's going to be attending is already online. So, Mark.
Where'd you get to the beginning of it? Let me get it all the way out.
This is that was your thumb drive.
Oh, here we go. It was upside down. All right, there we go.
Okay, just go back into Zoom for a second.
Okay, great.